Trach.
Welcome back.
Might have to call you on.
Good morning. When did you come back? Last night.
Oh my God.
Yeah.
Okay, all right, I'll probably.
Everything's okay? Everything's okay.
Thank you. All right, bye-bye. Oh my God, this is bad.
All right, where's the?
Because I'm like waiting to come up. He says he's awake. I don't know if I believe it, but that's what he says. Hey, you guys, let me just put some trachs out here real quick.
Educator.
Yes.
7:45.
Yes, charge nurse.
Okay.
7:45.
See how many people we have.
There we go. Everybody sign in. Sign in, please.
Okay.
Right here. So, I'm gonna pull these different trachs out that I was able to get samples for. And
Before I
yeah, go ahead.
forgot. You know, Rolodex.
Rolodex,
From
yeah.
MH.
Yeah.
We have 3 older ones.
Oh, yeah,
If
can
you
I
want
have
to practice.
I do want it.
Yeah.
We'll take it to the sim lab.
Yeah. Because we got the new one because it almost expired. So I said,
Awesome.
let's take the older one.
Yeah.
They already tried that. When you come, I can give it to you.
Thank you. No, that's perfect, Sam. Thank you.
Good morning.
Oh, hey, good morning. How are you? You look different than the blue scrubs.
I know. No more.
Everybody signing in? So I was a little bit better at this during surge training, but now, considering that wasn't that long ago, I've since forgotten everything. Isn't that terrible?
Yes.
Yasmin, do you see a trach color on any of those drawers before I bust it?
So you know what? I think no, that was over at Falls Church. I don't think trach collars come on there, but they do come in the package.
No, I mean
The foam ones.
the foam one.
Yeah, so I don't know if they were when we did eat. When I was at Falls Church last week, we opened it up, and they did not have them, so we went to the ENT clinic and grabbed a couple.
Okay.
It's not a priority.
I mean, that we can use, but
Yeah, the trach collars are nice, and maybe the pack you can get them.
yeah,
This is at least for the time being.
yeah.
Most important thing: do not let go of that track.
No,
Do not let go of
the trach's in,
Here,
throw
you
it
want
in, and
a
then
leftover flyer from the surge? You want a flyer? This is left. Don't worry, I didn't. This is just leftovers, okay? All right, there you go. Have a you want a leftover? Oh, whoops, wrong flyer. What? You're welcome. Here you go. There, Pam. Would you like a flyer?
Oh, sure.
I don't want you to think I did anything extra. These are just leftovers, okay?
Oh, okay. I was doing a good job, you know, so I don't have to.
No, don't say that. Don't say that. They were like, "Oh, look at all these." I said, "Okay, I'll take them." Right? It's really more for like airway management at the bedside than it is here. But let's go. I know we're waiting for Dr. Khan here. I mean, I texted her. She comes, but if not, you know I can talk.
We all know. What's the
we all know you can talk.
I can talk.
That is
But nice talk though.
Surprise, surprise.
Hey, morning.
I have a chew. Wow.
Oh, you do?
Actually, go special.
Oh no, this is trash. Oh, this is extra. Hey. So safety message. Anybody have a safety message they want to share?
When you are bring the patient, if you circulate, you will make sure you have everything ready before you bring the patient.
Oh, what happened?
Nothing. I'm just scanning.
Oh my God. Don't forget to sign in. Okay, safety message. Don't forget to make sure that you guys have everything ready. That includes implants.
Everything, implants, instrument ready, and equipment ready. And if you're not sure, check with the surgeon. That's the right one. And before you bring the patient.
Time out. Please do your final timeout before incision. Alright, the initial timeout is not enough. We have to do another timeout before incision.
And do you guys know what goes on that timeout? Sorry. What goes on that timeout just before incision?
No, we got a sign.
You have a sign. Is the prep dry?
Prep the surgeon we're doing,
Shock.
sharp zone, and where the fire extinguisher is at.
Yeah. Okay. There might be some extra things in there, but that's
Well,
okay.
probably the procedure, the
Yeah.
right side.
I think that you have to see the mark for sure.
Yeah, Mark.
Is the prep dry? Is there a sharp safety zone?
And
Alright.
where the fire extinguisher.
And where the fire
Um,
extinguisher is.
Another reminder about wearing gloves the whole entire time. You were not allowed to wear gloves and use of alcohol to sanitize that gloves. Okay, that's well, some people in the building or still do that. So yeah, please follow the 5 steps of 5 moments of high hygiene.
Repeat that again. So what about gloves and sanitizer?
We're not allowed to wear gloves at all time.
Yeah.
Walking around using hand sanitizer to sanitize the gloves that we're wearing.
Yeah. Okay.
Reminder about the laminated timeout card. We have to wipe that after timeout. Okay. Because we usually sometimes we put it on the top of the patient, so just remind to. Our hair, we have to contain our hair all the time. You know, be like hanging hair. We make sure we check everybody.
And if you have earrings, remember, you shouldn't be wearing earrings back in the OR, but if somebody else is wearing earrings, like a surgeon or something, they must cover them with the net. The hair, this bouffant, whatever this thing is.
All right. And that, 1 minute.
Yeah, go ahead.
There's a talk between the HR and the labor. There's going to be a lot of changes this December. Okay.
This is being recorded.
Oh, is it recorded now?
Yeah, I'll
Alright,
edit
so
this
I'm
part
gonna-
out.
We're gonna keep you posted. They're still finalizing it. I don't want to give you wrong information. But one thing is, you have to submit your request, vacation request, by the end of the year, by November 13th. All right.
For everybody?
For everybody.
For the year?
No, for this year. You have to request by November 13th.
Does that include education and personal? Okay.
I don't know about vacation.
Oh,
We're done
okay,
with
cancel
vacation,
that,
right?
just vacation.
So we don't
Max
know the
vacation.
detail yet. We're gonna
That's
see.
during November.
Yeah. And that's it. That's one of the highlights. I'm gonna keep you posted with the rest of the changes. Okay.
Just one more thing, and I want to say thank you to everyone this week. We're super busy, and
Yes.
especially for our assistant SARFA, and they always keep help me like when we send like scrap for break. You know, thank you. But I believe
Thank
we're
you.
gonna do today again. Thank you. You know, especially for this.
Thank you, guys. That's
Because we're super short. You know.
Thank you,
Super short.
Linda.
Thank you, guys.
Tracy, and Steve.
and
Okay, so my Thrive messages, don't forget your flu shot, please. Okay,
Flu shot,
and then
right.
Dr. Khan, we don't want to take any time away from you. I'm Yasmin, the educator. Come on over. This is being recorded so we can show it later.
Okay, sure.
Yeah.
So you guys know we did a difficult airway, actually not in the OR, in the pre-op and PACU area, and this is our difficult airway card. And one of the things that we might have to do if we don't establish an airway is do a trach. Okay, I don't think I've ever done a trach before, believe it or not. So I just want you to talk a little bit about I have the trach tray which we can open. We brought some suture and I brought some different types of trachs and how we would go about doing that. And you can actually trach this guy if you like.
Okay. Yeah. So, performing a trach on a patient for me as an ENT doctor, head and neck surgeon, that's what I'm doing after all of these things have been exhausted.
Mhm.
So, the anesthesiologist, the OR team would be attempting to intubate with the airway card.
Mhm.
So, for me as the surgeon, this is I step in when all of these things are exhausted, and really the trach, the only thing that we need is a blade. It's as simple as that.
Okay.
So actually had to do an urgent trach on a patient at Largo ASC maybe 2 or 3 years ago, where there was just some problem that was unidentified, some stenosis, and they weren't able to get the airway. And so in that situation, if I just get clear communication from the anesthesia team that there's nothing else that they can try, they exhausted everything in the airway card, then I just ask for a blade, and it's just incision down. It's probably going to be pretty bloody because we can't do the hemostasis that we usually do. To establish an airway, for somebody who is in need of a ventilator, right?
Mhm.
So the trach has to have a cuff. So a cuffless trach is a trach that's used just to, in an awake patient. So this is a trach that's cuffless. So there's no cuff on this trach tube shaft. Okay, so this would be a trach that somebody would wear if they were a patient that was not in an inpatient setting, that was not hooked up to a ventilator. Let's say they had some kind of vocal cord paralysis or you know, laryngeal stenosis or something to that effect, where this is just their way to walk around and breathe. If that patient needs to come in for an outpatient procedure where they need a ventilator, then they must, there would be an air leak if you tried to hook up a circuit to this trach tube, and that's the reason for the cuff. The cuff is to, you know, close the circuit and allow ventilation to happen on a ventilator. So, you know, so in terms of what's relevant to us, you know, somebody who would come in with a cuffless trach would need to be changed to a cuffed trach. And in the emergent setting, you know, what needs to happen is a cuffed trach tube needs to be introduced with an obturator. So with the box, we have an obturator. So cuffless and cuffed, all trachs come with an obturator, and the point of the obturator is to introduce the trach tube. So let's say a patient has a mature trach tube, a mature tract. You know, they've had a trach that's, you know, placed over a few weeks ago. That's usually a well-formed tract. So if you were to just try to take this trach without an obturator and put it in, it doesn't seem intuitive, but chances are the soft tissue would catch on the opening of this tube here. So the point of the obturator, obturator goes in and just creates kind of like this streamlined, pointy part that makes it easier to introduce into the trach tract without catching on the tissues. So the obturator is meant to introduce the trach. Once it's introduced, the obturator is removed, and then an inner cannula is placed. And so this, I think, is a cuffless inner cannula, right?
I think that's one. Yeah. You know, here's some others.
So, so the operator is just to introduce the trach in, and then to actually make the trach, you know, connected to a circuit. The inner cannula is then placed. The other point of the inner cannula is so that if somebody is, let's say somebody has a trach at home, it's not in a setting where they're hooked up to a ventilator, you know, the trach tube gets clogged with tracheal secretions, and so the point of this inner cannula is to be able to remove and sort of unclog and get rid of the secretions without having to take the whole trach in and out. So that's the point of the inner cannula. So, so that's kind of I think that's the most important distinction about the trach's cuffed versus uncuffed. Mm-hmm. And in the urgent setting, you know, if all airway options have been exhausted, you know, ENT surgeon will make an incision down to the trachea. Any kind of tube can cannulate that opening in the trach. So if it's a situation where somehow nobody can find trach tube, you just grab a thin endotracheal tube, and that can go in and be inflated with a cuff until we can actually find a trach if there's an actual trach that's available. So that's just kind of an overview, sort of the general.
So that's it. Can you also talk? So we have the most important thing about the cannula is all of ours in an emergent setting are going to be disposable versus non-disposable. So in a patient who has an older trach, they're going to have a non-disposable inner cannula, or they could. So it's important that you don't throw that cannula away. Right. If we have a disposable cannula, we should be getting a kit, I think, that has that disposable cannula in it, and you can replace it. Okay. So after I kind of wanted to open the tray up, what kind of blade are you going to need? So we had this discussion earlier, like what blade? We all had different ideas about what blade. Has anybody ever opened our trach tray? No, I've never opened it either. I have no idea what's even in here. So I wanted to open it, and then I'm sure all the trachs that we have are cuffed for that reason, for the ventilation. And I'm sure we don't have fenestrated trachs, but do you want to talk a little bit about the fenestrated?
Fenestrated trachs, you know, in my training, we didn't really favor fenestrated trachs. The point of a fenestrated trach is to allow a patient to speak if they have a trach in. So there's a little fenestration in the tube. You know, when a patient has a trach in, and if they have a cuffed trach in, they don't really have a mechanism to speak because their vocal cords are above this point, and their only airways here. To be able to speak, you have to be able to have air push up through your vocal cords, and so with a trach, you're below that point. So a patient with a trach that's cuffed can't really speak. So the point of this fenestrated trach is to allow mechanism to allow them to basically speak. I mean, separate from that, if a patient has a trach in and they want to phonate, they can occlude the surface of their, or the opening of the trach tube, which then forces the air up through their vocal cords and they can speak. So they can speak, assuming they're awake and not, sedated on a ventilator. So the point of this is to allow them to have a trach where it just facilitates speaking. In my training, they felt that this opening could sort of catch a lot of granulation and cause more trouble than it was worth. So I don't really deal with fenestrated trachs.
Okay.
I'm not sure there's really a good role for them necessarily.
When you're weaning a patient off of a trach, let's just talk about the different types of cannulas here, these here.
So if you're weaning a patient off of a trach, if the patient has a tracheotomy for whatever reason, if their clinical status changes and they no longer require a vent, then they're weaned off the trach, and that's kind of a sequential process where the first step is typically to downsize. So usually in a man we'll put in a number 8 size trach tube, and in a woman it'll be a 6. Those are just kind of the way the numbers go, typically depending on the manufacturer. So for a man, we'll usually downsize. So the first step will be, let's just change the larger trach to a smaller trach. So we would take an obturator, take the smaller trach, put the obturator through the trach tube, take out the first trach, and then just slide in the other one and let the tract kind of seal down to that smaller size. Once a man or a woman is on a smaller size trach tube, then sort of the next transition step is to remove that inner cannula and replace it with this cap. So the cap is this kind of sort of red cap tube here, and it's the same as not having a trach, because it essentially just plugs this opening, and it's like practice for just breathing through your normal airway without having this trach in. People have different methods for decannulation, but decannulation usually involves staying capped, if possible, and depending on your hospital setting, to have them on continuous pulse ox monitoring with the cap in overnight, because they may, while they're alert and awake during the day, have no problem with the cap in, but potentially it might be more of a problem if they're asleep with the cap in. And if that's the case, then they also need an exam in our office where we just take a look with a camera. We take out the trach tube and check for any stenosis or shelf or something like that, scar band that might potentially pose a problem when we ultimately remove this completely. Yes, because it's the same as not having a trach in, and it's the same as having a trach without a cap and just putting your finger over the trach tube.
As long as it's a cuffless trach, though, correct?
Yeah, I mean, it just kind of depends. So cuff versus cuffless. If somebody's trach tract is just a little narrower, they may have a cuffless trach in, but still have a pretty good seal around it.
Oh, okay.
So but you're right. Generally, that is something to consider.
Okay.
And then when it's time to decannulate the patient, it's just removed, and often that hole just seals down quite quickly. It might just be within a few days or within a week or two. Most of the time that just scars down. Sometimes there can be a persistent fistula, that might need to be excised in the operating room, but that's less common.
Okay. And the reason I wanted you guys to understand the difference between these two is because you might find that this might come in the trach when you open it. And I want you to understand what the purpose of it is. So don't put this in the patient when we're trying to breathe for them, right? Because it's totally occluded. We want to make sure we use the disposable inner cannula.
Right.
Okay, but that's the purpose of this. So you might not want to throw it away.
So in the emergent setting, the cap, that's just for later. That's for later outpatient. In the emergent setting, you need the obturator to insert the trach.
Okay.
And the inner cannula. That's actually a cannula that you put the circuit onto.
Okay. Are there any questions about this? I know when we haven't done something in a while, it's like you start looking at things and you're like, what's this again? So the most important thing about the trach is, and especially if we're like doing a dressing change or anything like that, is that you keep your hands on the trach at all time, because until it's actually secured with a trach tie, right, it could fly across the room and we could lose the airway. So this is a point where it's important to have good communication with whoever. My hands are on the trach. Okay, you can let go. That person's responsibility, and their sole responsibility is then to hold the trach until it's secured with the tie. We don't have those nice ones you guys have in the ENT clinic.
Right. Well, I mean, usually when we're putting in a trach, whether it's in the emergent setting or the elective setting, we suture it to the skin. That tie is kind of the secondary. Let's just put the tie around as a secondary reinforcement. So the primary thing is suturing it in. So you'll see us when we put a trach in. We don't do that routinely in the elective setting here. You're right. The hand is always on the trach once it's in, because even just with the positive pressure of the ventilation that the anesthesiologist is doing, it could come out or move around. And so the hands on the trach, and we suture it at 4 points, and then further secure it with a trach tie.
Okay, and so which suture do you use? We had this discussion earlier.
Yeah. So again, that's kind of more surgeon preference.
Okay.
It's non-absorbable. You know,
Okay.
whatever we put in is non-absorbable
Okay.
because it's meant to be removed later. So it's not the dissolvable stitches that go underneath, deeper in the soft tissues. So typically people ask for nylon.
Okay.
Some people use a silk. That's kind of debatable how absorbable that is, but or Ethibond. I prefer Ethibond because it's just easier to braid. So that's
Okay.
more surgeon specific, but the overall rule is non-absorbable and thick. Not a thin suture.
Do we have bedside trach here? We have a trach.
We have a trach tray?
No.
No,
No.
I did find this, the quick tray.
So you were going to go over some
Yeah, let's go over the instruments.
So in terms of a blade, either just a 15 or an 11 blade, any kind of blade is what you use to just make a skin incision. There are a number of different instruments that people might use. Some people use something called a trach spreader. I'm not sure if that's in here. Is that it? Yeah, this is a trach spreader. So this is something that's used to kind of spread open the incision. Your surgeon may or may not ask for this. There are many different ways to actually open the airway and enter the airway. So, for instance, if a surgeon cuts out, say, like a window from the trachea, they may not need this. This is more to just kind of spread open like a linear incision. It just kind of depends on the surgeon. Some surgeons will cut a flap that gets sutured to the anterior neck skin. So it's kind of more like a window you're looking in. So you don't necessarily need the trach spreader. But in the urgent setting, it's just any kind of opening, and we don't follow what we usually follow during elective procedures. So I think the main thing would be the trach spreader. Otherwise, it would be just similar instruments as before. This Craig hook is something that's that the surgeon might ask for. It basically just hooks under the cricoid cartilage, which is a ring of cartilage on top of the trachea, to kind of lift the trachea out into your further superficial into your field. Again, I think this is probably more for like the elective setting, but I think in the urgent setting, it might be. My method in the urgent setting is to just cut down, without really the soft tissue dissection that affords using these other instruments here.
Okay.
But I think the thing to just know would be the trach spreader, because this I think was probably the one thing that would be potentially asked for in an urgent setting, and the remaining instruments are will be something.
Yeah, so prep. You think we would prep during this?
If you can, yeah, but it just depends on how crazy the situation is. The trach is technically not a sterile procedure, so we do prep if we're doing an elective trach. In an urgent setting, if somebody remembers to throw some betadine or something on the neck, that would be great. But we're usually slashing the neck if the pulse ox is plummeting, so that takes priority over prep if the pulse ox is plummeting.
So what do you guys think is important that you need during, especially if we're in the PACU setting, when you're asked to come out here and help? What do you think might be the most important thing that you have available when she gets ready to do that?
All of this.
Okay. Well, then I was thinking of suction, right? So, make sure you know where your suction is, make sure you know where your suction tubing is, and that you have that available. So
I'm just looking to see if they have a section sitting up there.
So it is over there, but it's hooked up to the Yankar, so we might need to make sure that we have another one available, because they might need one for the mouth, and then we might need one for the incision.
Absolutely, I think. It would be a lucky situation where you're not running into a ton of bleeding, because there are blood vessels there that are normally, cauterized or tied off in the elective setting, and so in the urgent setting, there will be a lot of blood, and definitely the suction on the tube would be great. So suction and a blade are the two musts, and the other things can follow.
So just something to think about, because usually in the PACU setting, which is where most of these happen, there's only one, right? Any questions? How many people put a trach in? A long time ago. So I've done a lot of trach care. It's probably been about 20, I was trying to remember how long, 15, 20 years ago. So I had to do a lot of refreshers. Anybody have any questions about the different types of cuffs? Cuff and cuffless? What is the typical size that you might put in?
So
Six.
yeah,
and
so,
eight.
so I would say you just gotta grab a size. I would just grab a 6. Yeah, grab a 6. So again, the elective setting, larger patients. You know, a man with a larger caliber trachea, we put in a number 8. A number 6 would work probably just fine too. And it could be that the 6 trach is too big. You know, so I think that grabbing a 6 trach and also having the endotracheal tube, which should be on our cart, correct, or anesthesia cart. Because if that 6 tube is a little too big to get in, my next reflex would be to ask for a thinner endotracheal tube, something to cannulate the opening that I made into the trachea.
So we have these pediatric ones here. So some of the centers do not have the pediatric on the cards. I think that was decided by, but we do have, there's no difference except for size for the pediatrics, right?
For the most part, yeah. I mean, I think the pediatrics are overall smaller though, and in an adult, you probably need the tube to have more reach than a pediatric.
Oh, so they're shorter.
Yeah, so if you know, in the urgent setting, if the opening just seems too small to put a trach in, you know, then I would ask for an endotracheal tube
Okay, and not
instead of a pediatric. Correct.
So, okay, because I have a few pediatric ones.
And you always want a second one too, because you know the cuff could tear. You know, the second that the trach tube goes in, or the endotracheal tube, that's what we put in. That's the only thing we have. We have to inflate the cuff and check that ventilation is happening. And once the surgery connects, you know, is everything okay? Or do you get end-tidal CO2? If not, it could be that there's a cuff leak and the cuff is torn. In which case, then we'd have to switch it out for another one. You know, so I think you definitely want more than one of these things.
Okay, so I'm not sure, but you guys do have trachs in the ENT card, in the ENT
Office, yeah.
So I happened to run into Gloria the other day. It was so coincidental, and she actually does a lot of teaching, she said, with the trach in the past. And so Gloria did tell me that they do swap the trachs down there, and that they do have some extra trachs. I have not been there, but I did go to Falls Church ENT to check out what they had there, just so I was aware. So if you do have some time, you might want to run down there, Fan.
We did have like an exchange trip in the OR too. We
You
did
do.
several cases and also on the remove too. Yeah.
So do you have more trachs than this then?
I think we put some in the difficult area and they have more like in the supply.
Okay.
So in the ENT office, usually we're dealing with cuffless trachs
Yeah.
because we're downsizing, we're decannulating. I don't know if they keep a lot of cuff trachs stocked. You know, so I think that's something to
No, I don't
verify.
think normally
Yeah.
they ask
No,
for
just gonna
checkers.
say,
They
right.
are cuffless. Yeah.
Right.
So I did take all the expired ones at Falls Church. They had some cuffed, and I said, "Oh, let me have those," because they were all expiring for show and tell. Do you guys know when we have a difficult airway, it's really important to identify how many attempts have been made. You guys know how many attempts are allowed?
2.
How many?
2.
Not more than 2 insertions by one person, right? Before you go to the next one, but I think it's a total of 3. Is it 3? So if you follow this algorithm, it's really important. It's going to tell you exactly what you're going to use. Are you going to use the direct laryngoscopy? Then you might, if that doesn't work, you're going to go to reversing, and then let's see, can't intubate, can't ventilate. Then we're going to go to the transtracheal jet ventilation, and then surgical airway. We do have that jet ventilation in there. Are you guys familiar with that?
I've never used it.
I've never, yeah. So, and do you know that we have a reverse intubation tray in there too?
I was not aware.
Yeah, I didn't know that either. And then I was like, oh, there's one in there. So these are the kind of things that when we did our last simulation that while you guys might know what they are, but it might be something that you could offer as a suggestion. Hey, do you want to try the reverse intubation tray? You guys know what that is? I had to ask. It's okay. I had to go ask anesthesia. There's actually, I don't want to open it. It's a kit in there. It's by Cook. And there's going to be a needle in there, and they're going to stick the needle below or above the cricoid. I can't remember.
Just below the cricoid.
Okay, and they stick it, and then they thread this wire up through their mouth, and then they can thread a stylet over it, and then they can thread the tube over that stylet. It's like,
We should have in difficult area.
It's
also,
it.
we should in the emergency part.
it's in here for sure, but I didn't know we even had that when we were looking at the different methods. And I think that it's really important because as a team, we should speak up and offer, hey, we do have that reverse intubation tray. Is that something you'd like to try?
Do you know if there are bougies that are on this?
We have bougies here. I think there is a bougie in here.
Okay.
Yeah.
I wasn't sure if that was something that was in the anesthesia sort of.
It's on top of every, I think it's in here too.
Anesthesia part.
It's in here. So the other thing that, and you might be aware of this too, is that not everybody has disposable
Bronchoscope.
yeah. I'm like, what is, I'm trying, scope is what I'm trying to think of. So not everybody has the scope. When I was at Falls Church, I went over with the manager. I said, let's go over your difficult airway cart and make sure everything is good. They have a CMAC and they have the scope for the CMAC. I did not realize that that scope hooked up to the CMAC. I thought it hooked up to a video tower, which is what I'm used to. You guys know where this hooks up to? Yeah, we probably should figure that out. I'm wondering because it says Kaleidoscope on there. If
Yeah,
this
it's
hooks up
attached to a glass scope. So
it hooks up to the
That's
Kaleidoscope
possible,
machine
yeah.
probably. Because I did not realize that. So this is important that we realize these things. Lionel, do you know where this hooks up? This Kaleidoscope?
yeah, you have a special.
I did clip to the Kaleidoscope. So you need the actual Kaleidoscope to use this?
Yeah,
Okay. Where is that special thing?
it has a cable that's with the glass.
Oh, okay. So these are the kind of things, like I just thought it was a different scope. We hook up to our video tower, but
Yeah, they had that before, and then
We had the
we
old-
recently,
we still have the old
since we
one.
haven't do Glasgow, so they actually bought that piece.
yeah, to go hook up to the new
So there's
Kaleidoscope.
a pediatric one and there's an adult one as well.
Oh, there is? Okay. Is it in here? Is it pediatric and
Yeah,
adult in
this
here?
one is with purpose.
Okay. I don't want to open it. Okay, great. Thank you, Lionel. That was very helpful. So, but as team members, we got to think about that. If we're going to be going to a video, we need to make sure that we have the Kaleidoscope with us, right?
Just to comment a little further on the bougie, so just the same way that maybe you guys have seen the anesthesia, I'll just use a bougie, where it kind of used, the cylinder technique where, you put the long skinny bougie where you want your device to go, and then you thread the endotracheal tube over it. So that's potentially something that we might even consider doing for getting a trach tube. Same concept. It would just be, we're not usually asking for the bougie, but it might just be something that we're trying in your airway situation. So, that's.
Oh, just stick the bougie down. Oh, okay,
Yeah,
and then
right.
thread the trach over.
Right, if we had to, yeah.
Okay. Do you have any questions about the quick trach? I've never.
No, I'm not familiar with quick trach.
So,
The needle that you were talking about.
no,
Oh,
that
that's
separate.
no,
That's
that
a reverse intubation.
yeah.
This I'm not familiar with.
This is just a reverse trach.
That's a big needle.
Yes, it is. So it is. We do have several different things on here. Like I was talking to Dr. T-Brock, and because when we did our difficult airway simulation, we were talking about some of these things in there because I didn't recognize, and I worked in the ER and I didn't even recognize some of these things.
Yeah.
So what I'm hoping is that next year we're gonna actually take this cart apart and just kind of go through it and make sure that we understand everything. And then if we have any questions, we can get those clarified. It's always better to clarify before an event than after the event, right? Yeah, figure out all these things. Any other questions? Know your resources, Gloria. Gloria she is the common ENT. She seems very, very nice. That help earlier rather than later. So if we're going down this difficult airway algorithm, we might want to call ENT early rather than later. Right. Especially when if you're not even if you're not even sure, just go ahead and call.
How about after 5:30?
We always have an ENT doctor on call. Yeah.
But it's not like in the building.
Correct. Right.
But you could probably call CDU until ENT comes, maybe, just to get another hand if you need more help.
Right. I think that makes sense because there's staff by emergency room doctors who are also familiar with airway.
Yeah. So I did ask Dr. Treebook, I said, would you put in a trach? He said no, but maybe get it right the patient. They would feel more comfortable doing that. Okay. Any other questions? So I did give you a little handout, this leftover paperwork for our surge thing. So now let's go to COVID, because this is a COVID era right now, right? So when we're talking about a difficult airway in the PACU, we're typically not wearing an N95, right? So the first thing that you guys, we need to think of the patient, but we also need to think about ourselves. So remember, when we're going to be doing any kind of intubation, deep suctioning or anything like that, we do want to make sure that we get an N95 on ourselves, especially people at the head of the bed like ENT who might just be coming up here. And yes, while it's ideal to be fit tested for a mask, if you need something in an emergency, you just throw on whatever you have, because an N95 on is better than none at all, okay? If you know your size and whatnot, that's fine, but just give them something. It doesn't really matter at that point. If we're going to be doing any kind of deep suctioning on these patients, again, we're not going to, we might just suction the airway. We're not going to be going down deep. Just the cannula, just to clear any plugs and whatnot. You should probably wear an N95 as well.
Right. I think it makes sense. Those things generate aerosols, which are not just restricted to the 1 foot, square airspace right there. It's for everyone.
Yeah.
In the vicinity.
And if we can move them to an isolation room, that would probably be better too. But most likely these patients are going to go out to the hospital right away.
So what are you supposed to get the N95 after everything is done and the door is locked?
Is the door locked, Ludwig? Oh.
Charge nurse always have an access in my office.
Oh,
so you
Anita?
can always reach your charge nurse for
Okay.
stuff. The cabinet stuff.
Yeah.
Okay, so in the,
always reach out to your charge nurse. There's always charge nurse.
the other thing is, when we had the event a couple weeks ago, and who goes to the hospital with these patients, we did have to send an anesthesiologist with them to the hospital. So I'm not sure, is that something you guys would consider doing, or would?
I don't think it's conventional, because they're the ones that kind of are managing the ventilator, right? We're talking about intubated patient.
Yeah, they
Be on
just
a
bagged them.
ventilator.
I don't think they put them on a ventilator. I think they just bagged
They
them.
bagged. Okay, yeah. So usually, like I think as ENT surgeons, we're trained. This is how you bag. This is the bagging technique. But obviously, the anesthesiologists are the best at it. They're the ones doing it. We are aware of it, but it's not in our muscle memory as well as it is for them. So I think either if there was a situation where an anesthesiologist could not accompany, I think we would be able to step in for that. But if they're on a ventilator, definitely.
Yeah. So have those conversations before the EMS people come, if we do have to send them. And then finally notify the family, right? Always let the family know what's going on. Okay. Any other questions? We covered COVID. There should be suction stuff in here if we do need to suction them. And I give you guys those handouts. Does anybody want to practice with the trach? Okay, why don't you just demonstrate how to put the trach in real quick? Here, let me get one
So you open up the box, and what do we see in the box? We see this, this, right? Okay, so what's one thing I should do when I pick this up, if you have time?
Take it over here out of the cup.
Check the cup, right? We didn't talk about that.
Oh, no, we
So-
didn't talk about
Yeah,
that.
so that is like before I put a trach in, is the cuff trach in, is the cuff tested is what I want to ask, and I want to see it too. I want to see somebody put a syringe in if they're testing it for me. So so we would test it, to make sure it works, and then you're right. So obturator, right, goes in first, right?
How many cc's do you test it with?
This is a 4. This is the wrong size. It's too small. Where's our?
Here, I got that.
Okay, there we go. That's the obturator for it. This is the obturator for another trach. That's why it didn't fit. Sorry, what was somebody asking just now?
How many cc's?
How many cc's?
Oh, yeah. So when you inflate the cuff, there's not an exact amount. It's more of a feel thing. So definitely like 10 cc is way too much, right? Even 5 cc probably is going to be too much. So you don't want to overinflate the cuff. And this is just a technique thing, obviously in the urgent setting, you just want to make sure there's some air in there. But a cuff that's overinflated and staying in a patient can actually, cause pressure on the airway and eventually lead to stenosis and problems. So it should be inflated with it's soft, it's inflated but still pretty soft when you touch on it, without it being too inflated so it's so hard. And I think that usually ends up being maybe like 3 or 4 cc's from what I can usually see. Okay, so operator goes in, right? And now you have this here. Then you can introduce the trach. Some lube would be nice, but if there's no lube, we just put it in anyway. All right, and then once it's in, operator comes out, right? Okay, camera.
Yeah, you want to put it out? Put it.
Yeah, sure. Okay, so we'll put this in first, right? So operator goes in with the trach.
He's difficult.
Yeah, he's hard to get. Okay, he has the right curvature to follow the trach.
Here, try it. Yeah, okay. I was gonna say, try like this sometime, when I did this before. I know the mannequin is.
He needs lube.
There we go, it's in.
Okay, so then I take this out, and then what am I gonna ask for?
For the cup.
Inner cup, inner obturator.
Inner cannula, yes. So then inner cannula goes in, and then what do I ask for?
Suture.
Yes. I'm gonna ask the anesthesiologist for the circuit next.
Oh, yeah,
And we
yeah, yeah.
confirm that it's actually working.
Okay.
And let's say they tell me, oh no, I don't have end tidal, and let's say we determine that the cuff has a tear. So then I'm asked for another one, right? So we do the same thing again. Let's say we put it in, oh, this also has to be inflated right after it goes in.
Inflated.
Okay. So then circuit, and then you're right, then sutures. And then suture it. And we're holding it the whole time.
Will you have to exchange it and we'll take that one out and put another one in? Are we just gonna leave it open, or do you want something to go inside of
Yeah, that's probably when I'd ask for the Fuji.
that?
Right, because for us, like, to take this out means that I'm not gonna see the opening,
Right.
because the soft tissues will collapse, it's probably bleeding. So, this is the whole, like, you just can't take it in and out, because then you lose your airway. So if we had to swap it, that's when I'd ask for it.
So they do say if it does come out, you want to make sure you have an extra smaller one at the bedside, in case the hole shrinks up. So if you get a 6, you might want to go to a 5.
And, and also just the way to think about it too is, you're just in the urgent setting. Yes, a trach is ideal because it's the more permanent version, but if for some reason we can't find it, we don't have it, the endotracheal tubes will also serve the same purpose. We just don't insert them as deeply because they're not, going from here, they're going from here. So that would be the same thing. I would put in a trach tube, I would suture it here, and then, once things have calmed down, I would switch it for a trach because that's the more stable thing to be able to hook a ventilator to.
What's the smallest tube we have here, Colbert? What's the smallest tube?
You can have a cough and cough. I think for cough you have 3.
It's probably pediatric too, right?
Pediatric.
Yeah. It would have to be cuff. I know
Yeah.
the pediatric tubes, the smallest ones are cuffless, right? So it would have to be a cuffed, especially for putting it in an adult.
Yeah, because without that cuff, it'll just fall out.
And you don't have a closed
Oh,
circuit
we
for
won't have a
ventilation.
closed airway, yeah. Okay, I know you guys aren't familiar with end tidal CO2, or maybe some of you guys are, but that's really, really, really important for the anesthesiologists and the PACU nurses. Okay, so if you don't have, let's say you don't have the patient hooked up to end tidal CO2 for some reason, and you need to check it with, you guys know what we can use?
The CO2 indicator.
Yeah, there should be a CO2 indicator in there that you can use, and it'll turn yellow to purple to see if CO2 is coming out. But if at all possible, if you guys are assisting, make sure that that capnography tube gets connected. I'm not sure where it would get connected. I guess it get connected to the vent circuit.
Yeah, exactly. There's
They'd
a
have to get
connector
connected.
with a-
Yeah.
That's
So
what
the-
it usually is. But that's crucial because when we're like a trach tube or anything you're introducing into the airway can slip into a false passage. It just can sort of open up tissue planes and it feels like it's in, but it may not be, and that's why there's always a confirmation with a ventilator. The anesthesiologist will listen to the breath sounds too, just to confirm that we actually have an airway, and so that's very important.
Alrighty, well, it's 7:45. Thank you, Dr. Khan.
Thank you.
Alrighty, guys, thank you. Does anybody want to come up here and take a look or try practicing with the tubes?
That's a lot of damn instruments for a trach. Just saying. For a bedside crash trach, that's a lot of instruments.
Wow.
Yeah. Like literally you need a hemostat, a knife handle, and some retractors and something. You don't need thousands.
I think in a controlled setting, it might be nice to have all that stuff.
But like if you're in the middle of an emergency,
Look right there, you see right there in that baggage? There's some disposable, I just saw those there. So you know what, I think we need to take a look at those.
By the way, I laminated it for an everyone.
Oh, nice, okay.
Then I give you enough.
Yes, you wanna practice? Yeah. So there should be, now, I think in the code card, they've got sterile gloves, yeah. But you know, in all honesty, if they have to, they'll just, if it's non-sterile, they'll just be using the non-sterile gloves, yeah, right? So, but the sterile ones are nicer because they're thicker, right? Thank you, guys.
Next Thursday, they're gonna have make sure that it's up to date. Okay. Thank you, sir. This is the one that like.
I've never opened that tray, so that was good. So I will see. I don't know if I'm gonna remember all that. Now I have to stop my recording. I can figure out what battery. Now he told me to say